Hello and welcome to this session of Maritime Medicine, in which we'll discuss taking a medical history. By the end of this session, you'll be able to name the 8 elements of a complete medical history, perform a 6-point symptom evaluation, perform an 8-point history on a patient, and name 3 items that are important in trauma history that may not be relevant to a medical history. The history is basically your tool for collecting subjective information, that is, information that you cannot verify by any other means regarding a medical event. And it's typically focused. You're not doing a routine, well check, how you doing, history and physical. You've got patients that come with a specific complaint, and you're going to be assessing them for that complaint. Generally, a good history provides about 90% of the information you need to determine what's going on. That remaining 10% is made up by physical exam and possibly by some laboratory tests, but a good history really is what gives you the answer to what's happening. So any patient who presents to you, you need to get a history on. And as you look at the elements of the history, you can see how you might get some more than others. You might not necessarily get all the elements because you don't feel like you need them all, but you will definitely obtain a history because you need to figure out what's going on with the patient. Even in an unresponsive patient, you can get a history from the bystanders by looking at the environment, by looking at medical alert tags, or if this is a patient who's known to you, by old medical records. You can go through and evaluate all these resources to get quite a bit of information. For example, if you have a crew member who's a diabetic who often has low blood sugars and is unresponsive, you may know that as the medical PIC or the medical care provider, and you would be able to suspect that that's what's going on if you found them unresponsive. So there are 8 elements to a comprehensive medical history, and those are the chief complaint, the history of present illness, that is, how did the chief complaint come to be, a review of systems, past medical history, allergies, medications, family history, and social history. And we'll talk about each of these in more detail. The chief complaint is why that patient is coming to you. Why do they need care? And whenever possible, record that in the patient's own words. It's not always possible, but if they say something that clearly this is why they're there, put it in quotes, write it down, that's why they're there. So I'm having chest pain, or I have back pain, or I tried to kill myself. Those are all chief complaints. That's why you're providing care for this patient in this encounter. And it guides the rest of your history and physical. Again, you're not doing well checks. You don't have to do a comprehensive history and physical. You need to do one that's focused to the chief complaint. And ultimately, when you make an assessment, you say this is what I think is going on, and you develop a plan around that, it should in some way relate to the chief complaint. Now, you may well find out that the chief complaint is not what's actually going on, but someone should be able to look at your note and see the connection, the logical connection between that chief complaint and what you think is going on and what you're doing for the patient. For trauma patients, you have to understand if the chief complaint is due to trauma. And so that's not always obvious. A patient comes in and says, I'm having chest pain, or I'm having trouble breathing, or I'm having back pain. Unless you say, have you had any recent falls or injuries, or was this caused by a trauma, you may never know that in fact it was a traumatic injury. In addition, someone who falls and hurts their back and also has a little bit of abdominal soreness, that's one set of possible issues that you're dealing with. Someone who didn't fall but who had sudden onset of abdominal pain radiating to their back, there's a whole different list of things that you need to be thinking about. And so you need to clarify, was this traumatic or non-traumatic cause of the chief complaint? You then perform what's called a history of present illness. And this is a description of what led up to that chief complaint. Why did this thing happen? So there may be some short-term information, there may be some long-term information that's relevant. Short-term, I fell down a flight of stairs. My chief complaint was I hurt my back. There you go. That gives you quite a bit of description about why they're there. On the other hand, if someone comes in with a headache, they may say, I've had headaches off and on for the past year and now they're much worse. That's also relevant information. And it's all the information that the patient has given you regarding that chief complaint. And when it's relevant, it includes the last meal, and that may be the case in abdominal pain patients, that may be the case in nausea and vomiting patients, and you also want to know that in any patient with a traumatic injury who may end up needing surgery, and therefore you wouldn't want them to eat or drink anything else. Usually we start with the age and the gender, so we document a chief complaint of chest pain and we note that it's traumatic. And then in the history of present illness, we identify the patient, Mr. Albertson, or this is a 24-year-old male, so now you know the age, you know the gender, struck in the left chest with a packing crate that shifted and fell onto him. For trauma patients, you're going to describe that mechanism of injury. So looking at this history of present illness we just took, the mechanism of injury was struck in the left chest with a packing crate that shifted and fell onto him. Now you might need more details about that. Was it a little crate? Was it a 4-ton crate? How high did it fall? From what distance? But that at least gives you a mechanism of injury to think about. They should, or bystanders should, describe to you what happened. And unless you were a witness, this is all subjective information. This is not an objective observation of something that happened. And usually in your SOAP note, Subjective Objective Assessment Plan note of the medical encounter, this information is put into the subjective section. Now, if you then look at the scene and you see that the crate fell and struck the patient, you can document that at the end of the subjective section, or in the objective section, you could start with observation of the scene is remarkable for a broken packing crate that appears to weigh approximately 4,000 pounds that fell 20 feet from height to where it would have struck the patient, and then do your actual physical exam section. So you can put it in either, just so it makes sense logically in your description. Now, patients will have a lot of symptoms, and they may, as you get your history of present illness, reveal other symptoms. The same with a review of systems. You will find other symptoms. So, patient says, I'm having chest pain. Well, when did it start? It started 10 minutes ago when I was climbing a set of stairs and I had some chest pain and I felt short of breath and really sick to my stomach. Well, now you need to know a little bit more about those symptoms. And some of them you'll clarify in greater detail. Some you'll just say, okay, it's an associated symptom. But you start with onset. When did it start and what were you doing when it started? Provoking and palliating factors. What makes it better? What makes it worse? My chest pain got worse when I climbed the stairs. When I sat down and rested, it got better. What was the quality of it? Was it burning or stabbing or heavy or squeezing? My chest pain is a crushing sensation in the center of my chest. Radiation. Does it go somewhere else? So I had this crushing chest pain in the center of my chest, and it goes to my shoulder, it goes to my jaw. And you may have to ask the patient that. Does it go anywhere else? Up to your shoulder, into your jaw, so that you can get that information. Severity. It's a 0 to 10 scale or a mild, moderate, severe scale. And the 0 to 10 is useful. 0 is no pain. 10 is the worst pain they can imagine. Some people have trouble understanding what the worst pain is, and they'll tell you things like, I have this cut on my hand and it's a 10 out of 10 pain. Or, I'm having chest pain and it's 15 out of 10. Well, the scale only goes up to 10. So sometimes you need to clarify that. And if I have a patient who's being really pushy about this, I might say, okay, so here's how I would think of a 10. Someone is taking their hands, they're ramming them into your belly button, they're ripping your abdomen open with their bare hands, they're reaching in, they're grabbing your spine, and they're pulling it out through the front of your abdomen. That's a 10. Is this that bad? And often the rawness of that shocks them into revising it to a 4 or 5, which is probably a more realistic level. Now, you don't have to do that with every patient, obviously, but there are patients who will absolutely insist that a trivial injury is a 10 out of 10, and sometimes you just need to give them a sense of perspective. Then you ask them about the timing. Is it always there? Are there pain-free intervals? Does it wax and wane, but there's always some discomfort, and then it's worse when you do certain things? And all those together, onset, provoking and palliating factors, quality, radiation, severity, and timing, are OPQRST. So for every symptom, you can assess OPQRST. Once you've gotten your history of present illness, you may say, you know what, I bet there's other stuff going on. So you need to do a review of systems as part of that. And there you're looking for related complaints. And you're looking for complaints relevant to the chief complaint. So you may need to ask more about it, you may not. If it's something like, I hurt my ankle, you can say, is anything else going on? On the other hand, if they're having chest pain, you want to ask, are you having trouble breathing? Are you having any rashes? Are you having leg pain? Do you have fever? Etc., etc. And as you look at the 14 systems, you can start to see what sort of questions you might want to ask. So really focus on the relevant ones. Don't review them all. I have to review them all because I need to do that for billing. You don't need to do that for billing. So just review the relevant ones. So there are 14 recognized body systems, and some of these are more relevant to billing and coding, which is something you don't have to deal with, as opposed to actually doing an assessment of a patient. There's constitutional, which is your weight. Are you fatigued? Do you feel tired? Do you feel energetic? There's HENT, which is head, eyes, ears, nose, and throat. Now, for billing and evaluation purposes, the eyes are sometimes taken out. You can see they're listed as number 3 as a body system, but this would be anything from the neck up. Cardiovascular is an examination of the heart, but also pulses, skin color, circulation. Respiratory is breathing, but also includes things like something called clubbing, where the ends of the fingertips get rounded out in patients with chronic obstructive pulmonary disease, and they look more like little clubs. Gastrointestinal is everything related to the bowel. Genitourinary is everything related to the urinary system and the genital and reproductive systems. Musculoskeletal, that's pretty straightforward. Integumentary is related to skin, hair, and breasts. Psychiatric, well, that's pretty straightforward as well. It's related to the patient's mental health. Neurologic is related to function of the neurological system, so weakness, stroke symptoms, difficulty speaking, confusion. Hematologic and lymphatic are lumped together. You could separate them. Depends on what you're using them for. Hematologic relates to the blood clotting, so people who are covered with a lot of bruising, or people who develop blood clots in their legs. That's where you would find out this in your review of systems, asking questions about those things. Lymphatic is swelling of the lymph nodes. Immunologic and allergic actually relates to lymphatic to a certain degree, at least immunologic does. It relates to infectious disease symptoms. Allergic is related to allergies. And then endocrine is in many ways related to constitutional, but it has to do with function of the endocrine system. So diabetes, thyroid disease, adrenal disease, etc., etc. So once you've obtained a history of present illness, including your review of systems, and you've used OPQRST to clarify all the relevant symptoms, then you know what's going on related specifically to this chief complaint. And now you want to obtain some historical information about the patient. So you get a past medical history, which is a list of all prior or current medical diagnoses. And so you, in your role, really can't tell what's relevant or not. So write it all down. Is a childhood history of chickenpox relevant? Well, it might be. It might be relevant if the patient has never had it, so you ask about it and it's a pertinent negative. They say, no, I never had chickenpox, and now as an adult they're having chickenpox symptoms. It might also be relevant in your 56-year-old who's complaining of a burning, painful rash. Have you had chickenpox in the past? Yes. Well, who cares? That's important because now they probably have shingles. A list of all prior surgeries. You typically would list whether or not a diagnosis is active. So someone with childhood asthma who's an adult now and who hasn't had symptoms in 25 years, you can note that that's not currently active. It may be relevant. The fact that they had childhood asthma means they have this classification of diseases called atopy, and so when they get a cold or they get sick, they may be more likely to wheeze. Hypertension, you've got it now, it's active. And some people include tobacco use and alcohol use and abuse here. Others include it in the social history. Allergies are any allergies, intolerances, or other adverse reactions to medications, food, or the environment. And you need to list what the reaction was. People will write down allergies, and then that gets memorialized in the patient's medical record, and no one has any idea what the allergy was. And that can be really important. If someone is having chest pain, crushing center of their chest, radiating to their jaw, radiating down their arms, associated with nausea, vomiting, sweating, and a feeling of impending doom, they're probably having a heart attack. Aspirin will cut their chances of dying by 50%. They say they're allergic to aspirin. Well, what's the allergy? If it was a rash and trouble breathing, you're not going to give it to them because that's a very high risk that they'll have an anaphylactic reaction to the aspirin and they'll die. But if they tell you that their allergy was that it made them nauseated, guess what? We can treat nausea, and cutting your chances of dying from a heart attack 50%, that's pretty darn good odds. They're going to get the aspirin. If they say they have a history of ulcer and they were told not to take aspirin, well, you know what? 4-baby aspirin, which cuts your chances of dying by 50% if you're having a heart attack, are not going to affect an ulcer. On the other hand, if you then are told that you're going to have to keep them for 3 days before they can be evacuated and you're going to have them on aspirin every day, then you've got to watch them because while they're not allergic, you do have to make sure they don't start getting bleeding from their ulcer. You want to list medications that the patient takes, and this is a general term for any self-administered therapeutic agent. So it can include medications, it can include herbals, supplements, and vitamins that patients are taking, and those are relevant. Some of them are highly pharmacologically active, and others tend to interact with medications you might use, so you need to know if they're on them. And then some will include substance abuse history here, so they would include marijuana or cocaine under medications. Others put that under the social history. You want to know all current or recently discontinued agents, and why do you want to know what they've stopped taking? Well, if somebody comes in and they're complaining of palpitations, they feel their heart racing, and just before they shipped out, their blood pressure medications were switched up. You say, well, what are you on now? Well, I'm on hydrochlorothiazide. Well, what were you on? Well, I was on metoprolol. Metoprolol is a medication called a beta blocker. If you stop taking it quickly, your body gets a rebound, high blood pressure, and fast heart rate. So that's relevant to know. And then for children, what's their immunization status? Are their immunizations up to date? And that's going to vary country by country what the immunizations are. So it's best to try to get a list of them if you can, if they're relevant to the care you're providing. For trauma patients, 2 other questions to ask are, when was your last tetanus shot? Was it within 10 years? And are you on any blood thinners? And that's the warfarin medications, but it's a lot of other agents as well. Even aspirin is a blood thinner, and they all increase the risk of the patient dying if they have traumatic injuries. So you really need to ask, what medications are you on? And then really clarify, are any of these blood thinners? You may or may not need to get a family or social history. A family history is any disease that runs in the family relevant to the chief complaint. So if somebody fell and hit their head and you're worried that they're bleeding, well, there's a family history of hemophilia, a bleeding disorder. I've never been tested. Well, that may be relevant. A family history of allergy to bread mold is probably not relevant. Your social history is this sort of broad catch-all category. You really want to limit it to things that are relevant. So tobacco, alcohol use, and drug abuse all fall into that. But a marital status, the living situation if it's relevant, their occupation, that's probably actually going to be relevant shipboard. You need to know exactly what their role is because depending on what the illness or injury is, there may be restrictions for what they can do. But you typically limit this to just relevant information. And then you need to put it all together. Now, there's a mnemonic called the sample history, which captures all of these elements. And so I would strongly suggest you use some kind of paperwork, a form that guides you through performing a history and physical. And you use that every time. Until you've done 100 histories, you're going to miss stuff. So use that. But if you need something to kind of trigger this in your mind, the sample history will do it. So the S stands for symptoms, and that's your chief complaint, your history of present illness, your review of system. Those are all symptoms. A stands for allergies. M is medications. P is the past medical history, the family history, and the social history. L is the last meal, which you obtain under the history of present illness. And E are events leading up to the complaint. Then you need to document this, and the way you're going to document it is the SOAP note that's discussed elsewhere. This all goes into the subjective section. So the chief complaint, the HPI, your review of systems, past medical history, medications, allergies, family history, and social history are all elements of the subjective section of the SOAP note. Please complete any associated knowledge assessments, and if you have any questions, don't hesitate to contact your professor or instructor. Thank you very much.